pour ceux qui souhaiteraient avoir la traduction en français. Voilà.
Merci beaucoup pour l'introduction et pour l'invitation. Excusez-moi, je ne parle bien français, and I will speak in English. I will try to do in my Spanglish. It's much more easy because my accent is a Spanish accent, and then it will be easy. It's really, really my pleasure to be here. I enjoy a lot this morning with your presentations on dermoscopy. I like it, and I even every day enjoy dermoscopy. And I started now maybe more than 30 years ago. My first dermatoscope was brought to me by my professor at that time from United States, and he told me, I don't know how to use it, but I think it will be important. And it was in 1990. And then I use it. Let's start with Nevi, the essentials. These are my potential conflicts of interest, and these are the entities that are giving us funding to do research. And we will start with Nevi. And Professor told you how important is anapath, histopathology. And we know that the clue for Nevi are nest of nevus cells. And the traduction of nest from histology to dermoscopy is globules, aggregated of globules. This is the first criteria that we will see in the majority or in many nevi. But the second thing that we can see is a proliferation of melanocytes in the dermoepidermal junction, the melanocytic hyperplasia that can be associated to this nesting. And this melanocytic hyperplasia is, on dermoscopy, pigment network. These two criteria will be the basis of dermoscopy for nevi. And how nevi started? Usually, we are born without nevi or a mean of one nevi. But during childhood, during adolescence, nevi rise. And how they arise? With globular pattern. Most of nevi started with globular pattern. We did a study many years ago about the prevalence of nevi in children in Barcelona. And we identified some children with many nevi, but very few. Many times associated to other risk factors for melanoma, as this boy that maybe in the projection you don't see very well, but he has red hair, freckles, and many nevi. But when we see these nevi clinically, they are round in shape, brown in color, easy to diagnose, and on dermoscopy, globular patterns, globular patterns, globular patterns, globular patterns. Globular pattern is the predominant pattern in childhood nevi. But with age, reticular pattern increases in incidence. Also, we see in children homogeneous pattern. And homogeneous pattern is more frequent in young children and decrease with age. In fact, in our study, we saw that the predominant pattern was globular pattern. More than 50% of nevi in children are globular. But then the others, the homogeneous, reticular, or combination of two of these patterns. In fact, many other authors also analyzed nevi in children. And in this study, what was interesting is that they included 50 students, 10 to 12 years old, and they followed them for 1 year. And what they saw is that during follow-up, 36% of the new lesions appear, and the majority of lesions don't change the pattern. Less than 10% of the lesions change the pattern. Interestingly, in this continuation of the study that was a longer study, and they included more nevi, 70% of nevi retained the same dermoscopic pattern. Again, in children, we see globular pattern, but this globular pattern with age is transformed to the cobblestone pattern that we see in adults. This globular pattern growing when we see a rim of globules at the periphery. And these are the criteria that we see when nevi start. But the type under dermoscopy of nevi also change with age in adulthood and also with body size. And what we see is that the reticular pattern increases, and in adulthood is the more prominent pattern, reticular pattern. And later on, they decrease because these nevi are going to senescence. While globular patterns that move to cobblestone pattern, they lose pigment, but they persist. An example of adult with many nevi, all of them reticular pattern. Reticular pattern, reticular pattern, reticular pattern, reticular pattern. Sometimes reticular homogeneous pattern, sometimes with a little bit of asymmetry, sometimes with central hypopigmentation. But many of them stable during years. They can lose pigment, but it's something that happens slowly, not suddenly. And now we know that these reticular patterns are associated with UV damage, sun exposure. Reticular patterns associated to sun exposure. Again, in adults, sometimes we can see some rim of globules, a lesion that is growing. Young adults, it's fine. After 40, be careful. After 50, be very careful, maybe better to excise. Because after 50, we don't expect new nevi. And the differential is melanoma, okay? Rim of globules, growing lesions, is a hallmark of growing lesions. We have a confocal microscopy for many, many years, and we had the opportunity to analyze how nevi are growing. And we were obtaining confocal microscopy of lesions during time to see how they grow in few weeks, months, and years. And we were able to correlate all these criteria that I explained to you, the globules with the nesting, the reticular pattern with the hyperplasia of melanocytes, etc., etc., etc. But something that for us was really very interesting is to understand how the lesions grow. And one of the things that we saw is that those nevi with globular pattern, one subtype of them, when they grow, what was growing was the nesting inside the papilla. As you can see here, inside this papilla, in the second image taken months later, it was growing the nest inside the papilla. Then you can understand why a globule is transformed to a cobblestone, because they don't fit anymore. And they crash one to the other. Do you understand the concept? How they are growing inside the papilla. This is one subtype of nevi. From globular pattern to cobblestone pattern. And with years, they are losing pigment. Okay? But they stay. You know that we can move our dermatoscope, and the movement is completely different in nevi compared to seborrheic keratosis, that they move all in one. Globular pattern. That sometimes in papillomatous lesions, pigmentation can be irregular, strange, but we have other hallmarks. Coma vessels. Coma vessels are characteristic of this dermal nevi or papillomatous nevi. You can see here coma vessels. Characteristics of these nevis. Mature dermal nevi with coma vessels, and losing pigment. Probably is something that you will argue with me, and maybe you tell me, no, phototypes, dark phototypes, nevi keep pigment. Maybe yes. At least in our situation, the majority of dermal nevi are losing pigment. But there is another way that globular pattern with rim of globules can grow. And it's a completely different type of growing. The globules from the center are moving to the periphery, and they are leaving reticulation in the center. As you can see here, and you will see it later a little bit. I think I have the images here. Yeah, I will show you later. Something that is interesting is that in some studies, they demonstrate that growing lesions have more prevalence of BRAF mutations than other nevi. Okay, growing lesions, then you can see BRAF mutations. BRAF are very common. More than 50% of nevi have BRAF mutations. But if they are growing lesions, more. And RAS are more characteristic of congenital type. We will see later. And in here you see the confocal. It's in black and white. Maybe you do not know very well how to interpret them, but you see some bright white things that they are globules, correspond to nest of cells. You will see how in the next slide, that it was few months later, this central moved to the periphery. And in the center, what is remaining is pigment network. You see this reticulation? I will be back, nest in the center, and they move to the periphery. This is the second way how some nevi grow. At the end, rim of globules disappear, and you have just a reticulated nevus. It's also important to know, as we were discussing now, that the skin phototype is important in the dermoscopic appearance of the lesions. And now we know that fair phototypes have larger nevi and usually with central hypopigmentation, while dark phototypes have smaller nevi and more hyperpigmented or with central hyperpigmentation. In here you can see how when decrease the phototype, it means when phototype is darker, decrease the size and increase the pigment. Sometimes after sun exposure, we can have a black color in the center of the lesions, something that we call the black lamella. This black lamella can be removed if we apply scotch and remove the stratocorneum, because it's just pigment in the stratocorneum. Let's see now what we know about the different dermoscopic patterns of nevi. I explained to you that in children, we mainly see globular pattern. In adulthood, the predominant is reticular pattern, and we can see homogeneous pattern in children, in adults, but is less frequent and decrease with age. But something that we see many times is the combination of these patterns. But this combination of patterns usually has a symmetric distribution. Homogeneous in the center and globules at the periphery, reticular at the periphery and globules at the center, reticular at the periphery and homogeneous at the center, but also some new criteria that we see as projections or pseudopods at the periphery. For nevi, it's very important symmetric distribution of pigment and structures. Symmetric distribution and only two patterns, reticuloglobular, globular homogeneous, homogeneous globular, only two, and symmetric distribution, it's good. Three criteria, three dermoscopic features, and asymmetric distribution, be careful. We will see later in melanoma. Okay. Many years ago, Rainer Hoffmann-Bellenhoff described these different patterns of nevi, and he saw that any individual has a predominant pattern, and all nevi in one individual are similar ones to the other. And as I explained to you, they can be reticular, reticular homogeneous patchy, reticular homogeneous with central hypopigmentation, reticular homogeneous with central hyperpigmentation, globular, etc., etc., etc. There are only two patterns that we need to be worried about: multi-component and the star bars that we will see later. And it's very, very important to know that the majority of individuals have the same type of nevi. Then we can recognize the one that is different to the others, the ugly duckling sign on dermoscopy. And why is it important? Because melanoma can arise in a nevus. In fact, 30% of melanomas arise in a nevus or are concomitant in a nevus, close to a nevus. 70% are de novo. And patients with many nevi can have both melanomas arising in a nevus or melanomas de novo. Melanomas arising in a nevus are more frequent in people with many nevi. The risk is very low of transformation, only one nevi every 20,000 per year. But every year, some melanomas develop in nevi. It's also important to know that early melanomas can simulate nevus, and a typical nevus can simulate melanoma. And for this reason, it's important to recognize them. And she's a lady with many nevi, and they have many nevi, asymmetric with peripheral hyperpigmentations, very strange, but many were like that. And we decided to do a short-term follow-up. And this lesion changed to here, and these lesions changed to here. They were two melanomas arising in a compound nevus. It means be careful because melanomas arising in a nevus exist. Even if the predominant pattern is similar in one individual, some of them can be. Another example of a melanoma arising in a nevus, but in this case is a medium congenital nevus. And this hyperpigmentation here appeared during follow-up. It was before follow-up, after follow-up. Not normal. And again, with globules at the periphery, lesion that is growing. Be careful. When something appears at the periphery and with globules means that something is growing. Also, there are some gray dots and other suspicious things. And the lesion was an in situ melanoma arising in a congenital nevus. And this was the surgical solution for this case. Unfortunately, when the risk of melanoma is highest, is in patients with large and giant congenital melanocytic nevi, like this lady that had this central nervous system melanoma. But in here, the follow-up of skin, it's only able to diagnose 50% of melanomas that they develop because 50% of them are directly on the brain. And these are the images of this girl that we were following up until the age of 9. We lost the control and she came back at the age of 14 with scissors, and at that time he had the melanoma. This melanoma was NRAS mutated, and as I explained to you, the majority of congenital nevi, medium-sized, large, and giant, have mutations in NRAS. Let's move to another type of nevus that I'm pretty sure you know very well. Spitz and reed nevus. They are nevus fast growing. Evolution. The evolution is very, very important in these lesions. The mother always explains the new lesion was very dark, it's growing fast, and under dermoscopy we have this star bar spiral, characterized by these pseudopods or streaks at the periphery that you can see here with the confocal image, that they are nest connected to the central part of the tumor. Spitz nevi were very difficult to be recognized clinically. Clinically, only 18% of cases were properly diagnosed. Most of them are diagnosed in children and young adults. But the problem is that the main differential diagnosis is with melanoma. Okay? On dermoscopy, we see these unstable lesions. They can have a globular pattern, then a star bars, then homogeneous, then involutionate. And the problem is that the Spitz nevi are completely benign. We have the counterpartner, Spitz melanoma, that is malignant, with a different evolution that Spitzoid melanoma in adulthood, that has the same evolution as classical melanoma. And in between, a gray zone of lesions that we do not know their biological attitude. Those tumors now in the new classification are considered melanocytomas, just in case you listen them. But important, Spitz and reed in children When they are characterized as nevus by pathologists, they are completely benign. Okay? And at the molecular level, they have different signatures. Amplifications of 11p, mutations in ACRAS, BRAF, rare, but could be, and BAP1. She's a young girl, 2 years old, with a new lesion. This is dermoscopy, and you see how rapidly the lesion grows. Another case, in this case, is an immune-suppressed patient with a bone marrow transplantation, and again, this star bars pattern. It could be red, but it could be melanoma. What we are going to do? Excise the lesion, okay? After 7 years old, we prefer excise these lesions. In children and adolescents, many times they are benign, perfect. If not, at least we reach diagnosis. And in this case, it was just a red nevus, okay? But also we have non-pigmented spots, and non-pigmented spots clinically are very difficult. Many times they are misdiagnosed as warts, molluscum, bites, whatever. And the problem is that many times people are doing shaving. And this is a problem. Why? Because the difficulties in the pathology diagnosis are very high. And the criteria that allow us to differentiate benign spots from melanocytomas or spots, from Spitz melanoma or spitzoid melanoma that is the worst, is how the tumor is in depth. Mitosis in depth, maduration, etc., etc. And when we are doing a shaving, we are missing all the information in the deep part. Why I'm explaining that? Because with dermoscopy, we can recognize this pattern with shiny white streaks and dotted vessels and negative of the pigment network. This is a criteria for a Spitz tumor, and we always need to excise these lesions, except maybe on the face of 2-year-old child. But if the tumor is growing fast, even in children, we prefer to excise, because it's not anymore like Spitz, pigmented Spitz or red that with the star bars that they are flat lesions. These are pink nodules. The lesion is thick, and if I miss a melanoma, it will be a problem. Then, these are the different patterns that we can see, and Spitz red lesions, and we should be worried in front of pink homogeneous pattern with dotted vessels, the presence of shiny white streaks, and negative of the pigment network, and of course, any multi-component atypical pattern that looks like melanoma. Okay, we excise, okay? Let's move close to the end. Blue homogeneous. Blue homogeneous is blue nevi, okay? Can be a tattoo, but mainly can be an angioma, but mainly they are blue nevi. And again, mutations are different. GNAC and GNA11. Exactly the same mutations of uveal melanoma. And you know that these blue nevi usually are very stable during time. And finally, Sutton nevi, allonevus. Sutton nevi are more frequent in children and young adults, and they are more frequent on the back. They are many times multiple, and with time, involute, and hypopigmentation persist during months and years. This is the characteristic patient with Sutton nevi. Many nevi, and many of them with a white halo. And sometimes the lesion nearly disappears, is only pink, as you can see here. Under histology, a thick infiltration of lymphocytes and nearly complete destruction of the nevi. Sutton nevi are associated with vitiligo in more or less 20% of the cases and other autoimmune diseases. And many times is a previous history of sunburn. Asymmetrical halo may be present in some melanomas. This is a lesion with an halo, white halo, and under dermoscopy, very easy. Cobblestone pattern. And something so interesting, you see that one globule is far away from the other? Is because the lymphocytic infiltration is doing a separation between the globules, very characteristic of Sutton nevi. Sometimes they are a little bit strange, like this one with gray dots in half of the lesion. In asymmetric distribution, we excised and it was just a Sutton nevus. Okay? Sometimes they can be strange with gray dots, but just a Sutton nevus. And in this case, without halo, more difficult to be diagnosed, only with histology. But be careful, as I explained to you, even if it is not frequent, sometimes melanoma can also have a white halo. But in here, it's an elderly man with a lot of sun damage, full of freckles, a strange lesion in the center, asymmetric, and with a very asymmetric halo. And under dermoscopy, what we see is gray dots, blue-gray area, atypical vessels. Do you think it's a nevus? I'm not sure, but in any case, I will excise. And in this case, it was a complete regress in most of the areas, but just in this focal area with few brown globules, few nesting of a melanoma remaining. It was a melanoma nearly in complete regression with a white halo. Just to summarize, remember the criteria and the features for nevi. In children, dots and globules. In adulthood, reticulation. Homogeneous, blue or not blue, are much less frequent. Starburst pattern, the hallmark for Spitz nevi. What we learn, as I said, globular more in children, reticular more in adulthood. We have mixed patterns, and when we see the rim of globules, the lesion is growing. Remember, fair skin, large nevi, central hypopigmentation. Dark skin, small nevi, central hyperpigmentation. How the lesions involute from globules to cobblestone to less pigmentation but persistent with coma vessels or sometimes other criteria that allow us to recognize them. And the other nevi that grow with globules at the beginning, then reticulation, and then they disappear. Involution, senescence of nevi with reticulation. Senescence of nevi with reticulation too. And finally, the role of the oncogene BRAF, it's growing at the beginning and inducing senescence and involution later. With this, I finish my talk on the essentials on nevi, and thank you very much for your attention. Thank you.
Thank you.
Yeah, and Christina, she's one of my colleagues, and I wanted to put her today with me because she's the one responsible for congenital nevi in our department, and she follows now nearly 200 patients with large or giant congenital nevi. And for this reason, we had the opportunity to know all these things. Thank you.
Thank you so much, Professor Puig.